Welcome, everybody. We still have some folks logging in, so we'll give it just a minute and then we'll go ahead and get started. All right, we still have some folks logging in, but we will go ahead and get started. First of all, I want to welcome all of you here today, both panelists and participants. I'm Emily Transu. I'm an internal medicine physician and the Chief Clinical Officer here at Comagine Health. Kate Elliott, who was scheduled to moderate today, is unfortunately ill and unable to participate today, so I will be moderating in lieu of being a panelist. I want to introduce first a little bit of our process today. We're going to go through some questions with our panel, and then we'll have some time for questions and answers from the audience. This is a webinar format, so you will note that you are all muted. Please use the Q&A section for questions, as well as including any comments or insights that you'd like to offer. We will plan to address questions toward the end, but feel free to enter them at any time. For any questions that we are not able to get to live, we will work to provide written answers afterward, along with a recording of the event. I'm going to be brief in introducing our panelists in the interests of time. There's more information about each of the panelists in your flyer, and we can provide that afterwards as well. So today we have Evan Salino, who is a family medicine physician and the clinical director at Comagine Health. Nick Faulkner, Senior Director of Consulting at Comagine Health. Lisa Hollabaugh, Director of Patient Safety at Comagine Health. And Jen Brockman, the Chief Clinical Program Officer at the Iowa-based Compass Healthcare Collaborative, which is a close partner of Comagine Health in a lot of our work. We initially had scheduled Brian McClelland, and he is being replaced today by Andrew Burchett, Senior Director of Data and Technology at Comagine Health. We're delighted to have all of you here today. For background, all of you are well aware that the Rural Health Transformation Program is a federal initiative to stabilize and modernize rural healthcare systems across the U.S. It allocates $50 billion over 5 years, half of that to be allocated in equal amounts to all states who apply, and the other half to be determined by the HHS Secretary, with $10 billion released per year from fiscal year 2026 to 2030. These funds can be used for a wide range of activities defined in rural health transformation plans, which are to be submitted and approved by CMS. CMS has indicated that the Notice of Funding Opportunity will be released by mid-September, with a submission deadline in early November and decisions made by CMS by December 31st. The Senate added the Rural Health Transformation Program to the HR1 Budget Reconciliation Bill, or OBBBA, to stabilize and transform rural health care and to offset other parts of the bill that are expected to negatively impact rural providers, such as Medicaid cuts. I know that you are all very familiar with the program, but we will also put a chat link to a general overview in case you find that helpful as a reference during our conversation today. What's at stake here? We have strong, vibrant, and thriving rural communities across the country, but there are real challenges around healthcare in many areas, particularly around access and workforce. Many rural hospitals and clinics are also struggling financially and are further threatened by loss of income from Medicaid cuts and other federal changes. This program creates the opportunity for a lifeline for rural providers and the potential for transformation of care delivery in rural settings. At the same time, there are huge challenges. States have only a brief time to put together a plan that will serve their communities' needs over the full 5 years of the program. Among other things, they will need to balance the urgent needs of their rural providers with creating lasting changes that can sustain transformation beyond the program's 5 years of funding. All of us on the call today are well aware of these challenges. Why is Comagine Health involved? Our mission is to serve communities and to enable individuals and communities to flourish. Rural communities are a huge part of our mission, and for many of us at Comagine Health, including some on the call today, they are our own communities where we live and where we work. We want to do everything we can to ensure that the potential of this program is realized to the greatest extent possible. We're here as a convener. We certainly do not have all the answers, but we want to foster discussion and share. So let's start out by talking about the biggest opportunities here. I'd like to hear from the panel, from your perspective, what are the biggest opportunities that states have to leverage RHTP funding to make sustainable investments in rural health? I'm going to turn first to Evan for your.
Yeah, thanks, Emily. And thanks for just kind of laying out a framework for what we're facing. The thing that I see the most opportunities for states around is really fostering the opportunity for collaboration rather than competition for resources in these rural communities. Again, as you described, before any of this law passed or this transformation fund was in existence, rural facilities, rural hospitals, rural healthcare facilities were struggling in a variety of ways. And this is an opportunity to bring people together and form sort of a collective vision about how to use this time and the funds that are available to bring those folks together that are interested parties and try and figure out how can we enable better access, care, outcomes in our rural communities over this 5 years. What is the vision for that, and how collectively can we play a part rather than trying to solve one problem in one community?
Thank you. Jen, do you have thoughts?
I do. So I definitely see a lot of opportunity over the next 5 years to bring partners together. So hospitals, clinicians, patients, communities, to ensure better access, better care, and ultimately better outcomes across the country. I think one of the biggest opportunities to use this funding, and I come at this from a quality and patient safety lens, but is to put long-term quality and safety systems in place across rural hospitals and clinics. So rural providers already are pretty resourceful, and they do some incredible work with those limited resources. But this program really has the opportunity to give them tools, data, build peer networks to sustain those efforts. And we have the opportunity to scale and spread some of the successful innovations that are already happening in those rural communities and those rural hospitals. Investments in things like safety collaboratives, standardized protocols, and data systems are a huge opportunity here. And they really focus on strengthening the foundation of care, so we end up with sustainable solutions that last long beyond the funding. And I want to point out too that this isn't just about financial survival, even though that is something that is very real in rural communities right now. But rural hospitals often operate under constant pressure, and sustainability is often framed as separate from quality. But the Rural Health Program gives us the opportunity to align those two goals. So it's not really either or. We can reward hospitals for keeping access local and improving outcomes, and also build those sustainable foundations for care.
I appreciate you calling out that resiliency. I think that is such a cornerstone feature of rural systems and rural communities, and really an important thing to keep in mind here. Lisa, can I turn to you for thoughts?
Yes, thanks, Emily. I just want to call out a little bit. We have to really be aware of all the great work that's already happening in our rural communities and across the healthcare continuum, especially in looking at improving access and delivery of care. There are many new successful innovations that I think we can tap into. I think we don't have to start from scratch. So if people are concerned with, oh my gosh, where do we start? How can we look around at what's already being implemented in other regions, other states, through partnerships, and within our own communities, states, and networks? These solutions that are already in place have demonstrated measurable improvements for sustainability. And so looking at how does that move from perhaps a setting in which may be a little different than rural, come into a rural area and allow us to sustain those access points for a long-term service opportunity. I think we additionally have to look at the great work that's been done in rural communities with shared services and some clinically integrated network models that have already yielded benefits for rural settings. How do we further amplify that work through the use of these RHTP funds? The key message, really, the takeaway of what I'm trying to share is really how do we leverage what's already been done, the great work that's already been happening in our communities and our states, and make sure that we use these funds to advance that rather than start from scratch.
Thank you. Especially given the short timeframes involved in putting this together, it's a little bit mind-blowing to think of all of this coming together in just really a few weeks and months, and that I think underscores that importance of building on what's already been created rather than just starting from scratch. Thank you. It seems clear that engagement is really core to the potential success of this program, both deep engagement by clinicians and the community. How can state leaders really ensure strong engagement from both community and healthcare providers in their states? I'll turn to Evan.
Yeah, this sort of piggybacks on some of the stuff that Lisa was talking about. Overall, the main thing is, again, in this short time period, go and talk to those folks now. For state leaders, go and meet with the folks that are in these communities, figure out a way to, again, bring ideas together, because they have been solutioning and trying to be innovative with the resources they have. They have ideas about what their common pain points are, what solutions might be that might fit their community. Those pain points are really critical to focus on when you gather those. Again, like, what are the pain points that we could solve? A common one that comes up is like behavioral health, for example, behavioral health integration or lack of resources for behavioral health. So, for example, if that's one problem you want to solve and it's a common pain point across folks, yeah, pick that to solve. You can't solve everything, but that is a common one that just comes out and actually may provide workforce stability and allow use of technology and those sorts of things. The other key part of that is establishing structures over this time period to help continue to inform the process of implementation. So you're talking to folks now, you also want to talk to them once you have gotten the award and you know exactly how many dollars you're going to spend and what you actually are going to spend that money on. And then what is that structure? Is it a task force or collaborative, or what is that structure over the coming 5 years that can help the state, again, effectively implement the program and shift and pivot where it's necessary, or react to what's working and not working. So creating those regular outreach and input opportunities through structure is going to be a really important piece for state leaders.
Thank you. Jen, I see you nodding. Do you have things you want to add to that?
I do. So when we talk about engagement, the key is to really ground it in trusted clinician-led quality improvement efforts. And so in our experience, providers are much more likely to participate when the work that they're doing or that we want them to engage in ties back to improving care for their patients, not just compliance or reporting or checking a box. So if states keep engagement centered on that mission, clinicians, healthcare organizations are far more likely to really lean in. States have the opportunity to create simple feedback loops. So community voices, frontline clinicians, hospital leaders all have a seat at the table. And that kind of structure is what is going to be needed to build trust, because it shows that the decisions that are being made are shaped with local input and not just being dictated. So is another critical piece. So technical assistance, peer learning collaboratives, boots on the ground coaching can make a huge difference between a program that feels like an added requirement, one that feels like is really a genuine opportunity to succeed. And these supports send the message, we're here to help you succeed, not just another box to check. I think one of our biggest lessons learned in the time that I've been doing quality improvement is, and it's so important, is meet clinicians where they are and give them the support that they need. That really can be the difference between buy-in and burnout. Rural providers are under a lot of pressure, and engagement works best when it really aligns with the realities of their daily practice. And that means simplifying reporting, try not to add unnecessary burden, reduce duplication, and tailor the expectations so participation feels doable and not just another thing added to their plate.
We'll talk a little bit more about reducing burden over time, but that point is clearly a critical one. We can't ask things of our provider systems that they aren't able to do, and any plan that relied on that would not be able to be successful. So thank you for those points. There is a lot of centering of the language around this program around innovations in care delivery. And I think we're all excited about some of the innovations that have been enabled by technology and otherwise. What care delivery innovations might states consider that would really align with the goals of this program? And maybe I'll turn first here to Lisa.
Yeah, I think as we talk about all of the opportunities we have for improving care, bringing in behavioral health, as Evan talked about, and the collaboration that Jen has brought up a couple of times around patient and quality, patient safety and quality, I think one of the things that we have to consider is our workforce is going to be kind of the basis of what we have to get stabilized as we move forward into providing services in our rural communities. Thinking through how can our HTP funding either be combined with or used standalone to help develop that sustainable pipeline for workforce. Thinking through mechanisms that are already in place, I think, is a good place to start. We know a number of communities have a grow your own approach where they start with high schools. Maybe they bring in their colleges to do work during high school so that people walk out of high school with their associate's degree and ready for a nursing program. But how can we take this funding to help develop curriculums or different opportunities that then can sustain themselves when tied with a partner as a college or an educational institution to bring that work forward? I think starting young is really important in this work because we start to develop those career paths for our youth. And I think we have to also remember our senior population in rural communities. Many are wanting to still contribute in the workforce. How do we engage and bring them forward, and what's the benefit of that? Technology. We've talked a lot about technology. How can we better use technology for those training and competency evaluations and work, so that we're using our staff to deliver patient care and not binding them up with have to be in a classroom? So I think there's some opportunities for some collaboration and partnership to bringing in technology to provide some new solutions. I also think that we have the opportunity to look outside of our HTP funding to look at what are those scholarship opportunities that could be designed at a state level that could be focused on rural communities with the greatest need, and how can we incentivize people through the use of scholarships to provide time in these rural communities, embedding them and having them fall in love with the ruralness that happens in that and potentially staying in those communities. But I think it really has to be a collaborative across the state to look at workforce development, to keep people engaged, give them the opportunities, and then give them the means to continue schooling and get back into these rural communities. And I think by using these funds or looking at how they can develop a sustainable pipeline of skilled professionals in the rural communities we serve will definitely improve our ability to continue to provide access into the future.
Thank you so much. I love the grow your own approach. Um, such a resonant idea. Jen, thoughts from you?
Yeah, so again, rural innovation really doesn't mean that we need to reinvent the wheel. There's already things that are happening out there that we can scale and we can spread. And we know that scale and spread already works, and we can do it in a way that fits the unique needs and the challenges in rural communities. I think one of the biggest opportunities is for states to leverage quality improvement collaboratives to spread proven care models across rural systems. Collaboratives create peer-to-peer learning, which we have seen time and time again as a successful innovation or a successful implementation. It can accelerate the adoption of best practices and help rural providers see what's working in similar settings that resonate with them. And that kind of sharing is really powerful in rural communities where resources are limited. Um, the focus really should be on innovations that are rural appropriate. They improve safety, reduce harm, and again, expand access without adding additional burden. Rural hospitals and clinics need flexible, practical tools that can be applied in smaller settings that are resource limited. And, there are proven examples that we have seen out there that we know work. Sepsis care bundles save lives when they're applied consistently. Maternal safety initiatives can reduce preventable harm and improve outcomes for moms and for babies. Readmissions reduction programs help both patients and hospitals keep care local and sustainable. And these aren't, I mean, they're not experimental. These are things that we've been doing for years. There are tested strategies out there that with the RHTP support can be scaled to benefit rural communities.
Nick, do you want to talk a little bit about innovation with a little bit more of a technology focus as well?
Yeah, certainly. There's been a lot of good points made about technology investment and innovation. And I kind of wanted to take a little bit of a data look at this in a data lens. When we talk about bringing on new systems that are either going to collect data, share data, ingest data from other providers or collaboratives or the state, we want to make sure that some of those key concepts about interoperability and data sharing are baked into the plans at the beginning. There's plenty of systems that are already in place within every state, HIEs, there's state eligibility and MMIS systems, there's existing reporting systems. And it's important that when technology implementations happen, whether it's at a clinical level or at a state level, that those future considerations are considered up front so that they're not later add-ons or tack-ons. They should be really kind of considered right from the beginning. Part of the reason that's important in this case is that when it comes to technology and investment in technology, one of the key components here is making sure that those direct investments, which are going to happen, are long-term sustainable. So to make sure that when new technologies and new systems and platforms are built on, they exist for the long term and provide value, not just for the initial investment period, but long term until technology improves and they need to be replaced at some future date.
And Andrew, I see you nodding. Do you want to add to that as well?
Yeah, no, certainly. So yeah, I think a lot of the points Nick is highlighting is sort of a big area that could be focused on. Another area to kind of tie into technology is sort of workforce. We hear a lot about workforce and sort of the gaps that exist in these communities. And so commenting just from a technology lens, I'd say investments to build shared infrastructure or adopt shared technologies across, whether that be the state or a specific community that maybe crosses, state boundaries. I've worked on different projects there and seen great success. And so just thinking in systems, I would kind of start to do an assessment like what data are we missing? What systems are we missing? What are the jobs we are doing where maybe, a question I like to say is like, can we hire a tool to do this job, or can we hire a technology to do this job? And, as we look further in the future, we're going to be working, one of our coworkers, we joke about being a bot, right? And so working, alongside other bots and things that are kind of doing similar work or different work, different tasks. So yeah, just thinking about, tools and technologies you can hire. And I also think about on the platform front that Nick mentioned with data, sort of a pragmatic data and AI approach to technologies in that space that could help extend the scarce workforce that exists in these rural communities, to really give people time back in their day. So what, if you're thinking along the lines of what tool or what technology can I hire to do something, the goal there is to give clinicians and others time back in their day so that we already have that scarce workforce. Um, hopefully reducing that administrative drag could really make things easier on frontline teams. And I do want to just highlight, what Nick had mentioned about sustainability. While these tech builds are expensive up front, the key thing is that, long term, they're actually a lot easier to maintain and from a cost perspective. So as you look at these time limited funds, I think that technology investments could be a good use of funds to balance sustainability and build sort of capability in these communities.
Many of my physician colleagues have been very excited by some of the new administrative burden reducing technologies out there, whether that's ambient scribes for notes or options to help reduce the burden of prior authorization, extracting data from charts so that you don't have to spend as much time doing a manual chart review, identifying care gaps and following up on those. So a lot of exciting opportunities there, I think, in that burden reduction space, as well as patient-facing tools like apps and remote patient monitoring that could be really transformative in this space as well. So lots of exciting things there. A question in the chat kind of leads us a little bit into our next question. So from the audience, we have the things that we're talking about seem like they're not all very technology forward or transformational. It's a complicated word, isn't it? Transformation. Is the expected focus to be more on scaling existing functions or on supporting new approaches that drive change? I'll take a quick stab at that, which is I think it's truly a both and. There are many things that are allowed under the program, and I think that both of those are going to be necessary to really reap the benefits of this. I don't know if anyone in the group wants to jump into that, or we can start to talk a little bit more about some of those innovative pieces. And I'll go first. Yeah.
Yeah, I'll jump in, Emily. I mean, I think, yeah, we just talked a little bit about tech forward, and, it's often if you're looking out in the, all of the marketing and everything coming in is like AI, AI, AI. But in all reality, there's, basic systems, basic tools and technologies that could be adopted today in these communities that doesn't necessarily get you that far ahead in technology innovation, but is sort of more basic technology. And I would just say that a lot of that's foundational to even kind of make the leap to the future state. If your data is not in a good spot, if you're still sort of using clipboards or using places where data is not readily accessible, like spreadsheets. One of the things we talked about is like centralizing sort of a measures factory, as a lot of sites are drowning in spreadsheets and states are receiving, data in a variety of different ways. And so you could kind of build a system that maybe isn't using, advanced technologies, like AI or ML, but is actually meeting the needs and kind of advancing you forward in that sort of digital transformation, phases. So these funds, I'm sure a lot of these rural communities have ideas for projects, have ideas for systems, and ideas for what data they're lacking. And they probably either just lack time or lack resources, i.e. money. And so now this is sort of an exciting time that they could potentially jump on and leverage that. And, point I do want to call out that maybe I didn't make in my earlier statement, but is like, don't go at it alone. I think that there are lots of, rural communities, smaller organizations that maybe don't know where to start. And maybe there's, opportunities like Nick mentioned to collaborate with the local HIE, to collaborate with your state partners on those projects, on those ideas. Like, hey, if we had this data point, we could really do some, real good with that data being in our system.
Thank you. Jen, I saw you light up a little bit at the AI versus non-AI point. Maybe I'll turn to you.
It is a hot topic right now, AI, and technology really does play a critical role. But we want to make sure that it's a support, not a stressor. And I think some of the most powerful innovation is when training, coaching, and technology all work together to let rural clinicians practice at the top of their license. That's really what we want to do, reduce the burden and help them take better care of their patients. And I think looking ahead, there are some real opportunities to use AI in different ways that directly support quality and patient safety. I think predictive analytics can help hospitals identify high-risk patients a little bit faster. So, like flagging sepsis patients or predicting readmissions. We've seen work happening in those spaces. I think too, adaptive learning and simulation tools could be a huge opportunity for the rural workforce. It can accelerate training, and that is so important and valuable in rural areas where turnover may be high and there aren't a ton of resources. And I think when you use some of those AI tools or just technology in general, integration with the EHR, using AI-powered clinical decision support, it can help prompt evidence-based care pathways and help support clinicians. But I do want to make a note that it's important that we all understand that none of these are going to replace clinicians. They are 100% here to support them. So, the goal of these different technology integrations is to really support rural providers and give them the tools they need to deliver safe, reliable care that in a way that's sustainable for them and for the local communities.
Sustainability, clearly a key word in all of this. Let's talk a little bit more about sustainable partnerships and sustainability in general. Some questions coming in the chat on this topic as well. Nick, maybe I'll turn to you first.
Yeah, certainly. So when we talk about, building in sustainability, kind of getting to a very nuts and bolts approach to how you would go about doing that in some of these plans. There's a couple of things that we've seen be successful over time when kicking off a new project, making sure that that level of effort isn't just for the initial splash and then kind of effort goes away and kind of focus goes away. So some of the things that we've seen be really helpful there is integration into existing roadmaps, existing strategic plans, whether they be 1 year, quarter, 5 year, 10 year. Certainly something that I think kind of helps ground the work into existing ongoing efforts and really gives people a good understanding of how this investment is going to tie into the overall success of the efforts of the facility, not just of the effort, right? It needs to kind of contribute to the overall mission. Part of that is coming through in the planning phases with as you're developing roadmaps and plans and strategic documents, really being clear about what those key milestones are with time and effort. And then understanding what the outcomes of each of those efforts is intended to be, whether it's saving clinician time, whether it's improving efficiency, whether it's a safety and quality initiative, being very clear about what the outcomes expected are. And identifying measures to make sure that those things are on track or need some adjustment, or providing some lessons learned for how to better do things as this funding unwinds. We've talked about how the timeline here is not forever, but it's also not a really short timeline. There is a good, long, decent runway here where plans can be adjusted with information coming in. You know, if something starts to kind of not be as appropriate or as effective as hoped, you know, there's time to make some changes to improve and take that quality improvement lens, not just for the clinical care, but also for the implementation of the effort itself. One other item I'll mention here is that you know, we talked about sort of this theme of not going up this alone. You know, so I want to make sure that these investments are don't just have to be at the facility level. They can be with things like community hubs or networks. So this investment can be shared and the benefits can be shared across multiple different groups. It doesn't have to be that every group does the exact same project with, you know, a slightly different flavor. They can be combined and work to meet the needs of the larger groups.
Thank you. Other thoughts? I know, Jen, that Compass is sort of all about partnership, and I'd be interested in thoughts you have to share on kind of the sustainability of that partnerships piece specifically as well.
Absolutely. So I think sustainable partnerships in rural communities really start with trust. And one of the strongest ways to build that trust is through transparency. So I think Evan talked about this earlier. Collaboration almost always wins out over competition, especially in rural areas where resources are limited and every hospital success contributes to the health of the broader community. But you know, the health outcomes are not just happening within the four walls of the hospital. Expanding partnerships outside of those walls, to schools, working with employers, social service agencies, behavioral health integration allows those communities to address the root causes of some of those health issues, population health issues in the community that really can make a difference. We have seen personally that when rural hospitals have a seat at the table, clinicians have a seat at the table, and they engage transparently with a broad group of partners, they really create shared learning that strengthens the relationship across the community and the healthcare system in general. And we have seen too in some of the work that we've done that the importance of including those non-traditional partners. So like I said, the schools, employers, so social services agencies, those solutions really do become more comprehensive and they're stronger.
Thank you. Clearly, states have a huge amount to do in putting this plan together pretty quickly. Evan, can you share any thoughts on just advice you would give to states as they're putting this together?
Sure. Yeah. I guess I would put it with as three things. One is the piece that I already mentioned, which is engagement. That's going to be the basis of success of the plan. Is, you know, if you utilize engagement to inform the plan and then figure out how to listen to and incorporate ongoing input to change and effectively implement that plan over the 5 years, right? As you're recognizing things are working and needs are popping up that you might not have expected. So that engagement is going to be critical. Again, kind of repeating a theme, that collective vision about how to solve pain points is going to be critical. It is going to be really tough given the financial situation that rural healthcare was in and will be in, to for everyone to run different directions and try and solve their problem without working with other folks. States have the opportunity to bring people together, to bring folks together, to have that collective vision about how to solve some of those really key pain points. And then the last piece would be think about how to integrate, right? So utilize this 5 years to think about how to integrate these plans that'll be in this Rural Health Transformation Fund and the implementation of that into other health policy, into your Medicaid payments, into state regulated private insurance payments. If you're going the direction that everybody else in the country is going towards value-based pay and value-based care, how do across the patient panel that people take care of, the population, how do those things work together so they can synergize and encourage, again, that sustainability, potentially replace some of the dollars that we think we're going to lose by being more effective, actually giving better care, those sorts of things. And with that, again, how do we utilize things like technology and recognize the limited workforce and access in ways that we haven't done before, right? So, for example, if we have a network of folks or we have an HIE, and we recognize that there's a limited access to specialists across all of rural and frankly urban healthcare, there are ways to think about establishing things like a specialty referral network where across a state we could actually share specialty services. Folks could be in one rural hospital, they could be e-consulting or doing collaborative care with folks at another rural hospital where the workup could happen. So both entities could actually benefit financially. At the same time, the patient doesn't have to travel, access improves. Those things can be done with these dollars, but that takes collective visioning. That takes, again, not just 5 years of funding, but established strategies to build in the supports for those into existing payment programs. So that the integration is going to be really key, whatever the solutions are.
So many things to balance here. I think as we're thinking about what states need to do, there's also the question of what they need to avoid. Some comments in the chat that we'll get to later, but certainly a lot of concern about financial pitfalls and others. What are some of the pitfalls that states might really want to be mindful of as they are planning this work? And I think I'll go first to Lisa.
I think as I reflected on what could really kind of bind people up with this work is really thinking about infrastructure investments. While we're talking about technology as a solution, that means a lot of things to building out or doing things differently in our facilities. Thinking about access, it might be, do we want to invest in buildings or changes or modifications to older structures that still are out there in rural settings? I think we have to be very cautious about understanding the ongoing cost of those types of changes, because while the money is there and it could allow us to do some great and innovative things with infrastructure, I think that we have to be very aware of what are those ongoing maintenance costs. How do we use our depreciation funds, which sometimes get eaten into operations in small facilities? How do we really be transparent about what that ongoing cost is going to be, and how are we going to cover that, knowing that revenues may continue to go down for 10 years with Medicaid changes? So I think it's just about, while those may be real life solutions that we want to engage in, I think we have to be very aware of what is that plan moving forward. What if we run into unanticipated additional costs, and how is that going to be captured and funded? Because what we don't want to do is make the commitment now using the funds and find ourselves 6 years down the road in trouble because we now can't sustain what we implemented. So that would be one thing I think we need to be really cautious about in our work.
Lisa. Nick or Andrew, do you want to add anything to that? I'll go to Nick.
Yeah, I'll just add to say that not all costs are as apparent. So, the funding does have an end date, and be aware of potentially hidden costs. So, right, technology often has a licensing component or an ongoing user cost, but there may be upgrade costs down the road for those same systems, or as new requirements come on for security and data privacy, sometimes those has costs too. So, it's important in this planning to make sure that you're trying to look at all the costs that could potentially be out there, not just immediately, but kind of the long-term costs that may be not as apparent.
Yeah, those are some good points, Nick. I would also add just, is there a way to leverage these dollars and synergize them with other projects? I saw some comments in the chat about, on this topic, but, can you take some of these funds and tie them in with HRSA or with state state or federal, other state or federal dollars around a specific project or initiative to kind of make those funds, all of those funds collectively go further. And, as you think about these projects and these partners, you could also think about choosing the right partners that, have some funded initiatives or have some funded, dollars towards these things that they're trying to solve. So it's not just these funds, but what other funds or other projects or other partners that you can kind of link up with to make those dollars go further.
Thank you. Evan, anything to add there? You spoke earlier to strategy and might want to talk a little bit more about that.
Yeah, I mean, just kind of piggybacking on what Andrew and Nick said as well. There is a real need to be strategic. This is a lot of money dedicated to this fund and that states could receive, but it is not a lot of money relative to the needs in rural communities. So we can't boil the ocean. We really can't throw money at problems that we know are bigger than the resources we have and that we think that probably we can't solve. So we have to be strategic about what are the core needs, what are the key pain points that can be solved. If we could solve one key pain point or two key pain points, that is better over the 5 years to have a sustainable path than solving zero because we've thrown money at problems. Again, we just know we can't solve with the resources that we have. And so that takes strategy, that takes leadership. And again, it takes that engagement to vision and coalesce around what can make healthcare in rural communities across whichever state a little bit better in terms of access, workforce, the quality and the outcomes, the services that people, experience in those communities. And so that strategy is going to come from somewhere. Ideally, that's again states, but also it's got to come from those community leaders that will share their vision.
Yeah. A lot of questions coming in around that central challenge of the funds not being necessarily adequate to balance the loss and the challenge that rural providers are facing in that space and in that balance. One of the ideas that's come up is some things around alternate payment models and how value-based purchasing or other components of value might pay into the funding here. Does anybody want to comment on that at all? And we'll go to Evan.
Sure. I'll just, so value-based pay structures, if they're set up correctly, and again, across multiple payment streams, Medicaid, private insurance, Medicare has their own strategies, but there are a variety of strategies that folks can work in. If those are aligned, then there's a real opportunity to make different outcomes happen and change processes and bring additional dollars in for those targeted interventions. What we see too often is those things are not aligned. Maybe there's one thing that's partially done in one program, but not others. And so, again, thinking about the folks providing care, what they want to do is take care of the folks they take care of the same way, depending on their needs, across their population and not have to figure out which payment model supports what. And so, for example, again, I mentioned that specialist network, primary care specialty network, that would work if we figured out a way to share finances across organizations. So break down some of those organizational walls and share care across organizations, right? That takes some work and could be supported through direct payments to specialists, to primary care, to hospitals, to actually, again, sustainably support that work. Then the rural health transformation dollars might pay for the technology to support that work. So, thinking about this in buckets of funding, it doesn't have to be all this rural health transformation dollars. And yet, again, if you structure your value-based payments correctly, to pay for infrastructure, to recognize the value of breaking down some of the organizational silos and taking care of communities, then that's going to lead to a lot more success than piecemeal approaches or like just inserting more quality metrics into payment. That's not going to work.
Specific to quality metrics, there was a question about whether we have seen any state try setting a standard for value-based contracting metrics, for example, aligning with the Medicare ACO metrics, so that clinics can engage in value-based relationships without having to chase multiple conflicting measures, or even chasing grant deliverables over outcomes. This is a familiar challenge, I think, to all of us. In my work in Washington State, worked with Washington's Performance Measures Coordinating Committee, which seeks to do exactly that, to set a limited number of metrics so that we don't have people chasing many and frequently different variations on the same basic measurement concept. I will say it's challenging. Everyone wants alignment, and many people mean by that they want everybody else to align with whatever they're doing, rather than to have to make changes themselves. But there definitely have been states that have made these efforts. That's been going on for quite a long time in Washington. I know that CMS is also really seeking to create a more standard set and to align its different programs around that as well. Other thoughts from anyone on the panel on that question of measures alignment? All right. Question around how states will decide what parts of this go to rural hospitals versus to outpatient centers. I think much of this is state-based and to be decided, but Evan, do you have any thoughts on that?
Yeah, I guess, I mean, to me, it's going to really depend. It's going to be very state dependent and community dependent. What I am hearing in talking with folks in rural communities in my state, which is Oregon, and folks in other states that we work, for example, Idaho and others, is there are defined needs, access needs in certain areas for things like maternal health and emergency care, surgical services, things like that, that if those go away, then folks have to go a really long way for care. And so states may prioritize places that provide education or workforce training and or particular services in terms of hospitals and hospital-related training facilities, et cetera. At the same time, again, the funds clearly can go to outpatient services, and what will be the most effective and the most innovative, frankly, is for folks to be out of their silo of I'm a hospital, I'm an outpatient clinic, I'm behavioral health or whatever, and figure out a collective plan to work better together. So that's the patient-centered plan. Is patients, turns out, aren't only in the hospital or aren't only in the outpatient clinic or aren't only in mental health. They move between all of those things. So if you take a community-centered approach and you're thinking about the patient's journey, thinking about how to make that work better is going to be a collaborative effort. And that is going to involve some specific support for hospitals. It's probably going to involve some specific support for outpatient services in a variety of ways, and community-based services, right, where folks really are going to have additional needs. But the benefit or the transformation part of this Rural Health Transformation Fund, to me, is figuring out how to get those folks working together so that the patient's journey, they get to where they need to go. They get the care from the hospital if they need the hospital care. They get the care from mental health if they need that. There are services available for them to get the care. And so we improve access rather than just stemming really important but difficult problems in things like finances of a hospital, right?
Thank you. I have a question around how relatively new tech-enabled clinical service companies can best get involved and make a difference with this program. Andrew or Nick, do you want to offer any thoughts on that?
Yeah, I mean, I would just chime in and say, people are looking for, they have jobs to be done, and can your product or service do those jobs? Can they hire your product to do that job? And that's part of the jobs to be done framework, if you're familiar with that. But that's kind of how I would think about it. If how does these newer tech enabled companies plug into this? It's reaching out to these customers and understanding what their pain points are, and if there's something that you could do to help solve those pain points. I don't know, Nick, would you add anything?
I would just say if appropriate and there's places to plug into some of the collaboratives we talked about, that's a great place to hear and learn about those issues firsthand. I mean, the best person to tell you what is needed is the person who's going to ultimately potentially use the thing that you're building. And sometimes the best way to get that information is just directly asking or listening. And so I would say, yeah, if there are ways to participate from a listening and learning perspective, that's really going to be a really good way to inform what you're building to make sure it meets the needs and it's a good fit.
Yeah, and also to hear, common pain points, and even procurement information sometimes comes out of these groups of, hey, we're looking for a vendor to do X, Y, and Z. And we hear that from a lot of these associations as well.
About how to get engaged are coming in on a couple of different topics. We have a question from someone representing the Nevada Occupational Therapy Association, who are interested in using this to leverage OT expertise in prevention and community health, fall prevention, care coordination, transitional care, as well as reducing ED utilization and readmissions. What is the best mechanism, point of contact, submission format for them to use in kind of offering to collaborate on that, and how would that work? I think this is both a great call out on the importance of OT folks in bringing together this very package of what care looks like in rural settings. I think other a little bit further afield from the kind of standard care provider list, folks are also incredibly important to this process, whether that's thinking about community paramedicine, whether that's thinking about the role of pharmacists, which can be expanded far beyond what they traditionally do, as well as community health workers and others. So maybe let's take this question in two parts. Anybody want to offer any thoughts on the role of some of these other providers here? And then we'll have a separate thought on how to bring those ideas to your state.
So I'll jump in on that. I mean, Emily, I really think as we look across what's available in our rural communities outside of kind of traditional physicians, nursing, CNA roles, I think we have the opportunity, as we're looking for solutions, to reach out to those people that are working in these different continuums that can bring ideas forward. We can integrate, because as we look at solutions, finding the best place to provide the least cost for the care that we need to provide is going to be critical. If it can be provided in the home, it should be provided in the home. If there are experts like our occupational therapists that have so much information around care for people in any location in which they're setting, we need to be bringing those groups to the table for collaboration and asking for their input and feedback on how we can maximize the care we provide in any setting.
Thank you. Question as well about how social determinants can be addressed in applications. This came up a little bit earlier in conversation. Anyone want to speak to that a little bit? Maybe Jen or Evan, go ahead.
Yeah, I was just going to say, again, yes, connecting what I would call as health-related social needs potentially to these efforts, things like community health worker roles, folks that, again, are interacting with people in their community, in their home, not just in the clinical space. Those are critical roles. We know those are evidence-based interventions. And so where there is evidence and we want to spread that ability to have a workforce that actually can reach patients for education, for chronic disease management, for other things, and to address social determinants of health or health-related social needs, which again is my preferred term. That's the effective way to get better health care. At the same time, again, that allows, in some sense, an economic strategy. How can we, in our communities, grow from those communities and utilize who is there to serve some role here, to create that ability in communities where it doesn't exist, so that there's employment there, keeps people there, and they're contributing into the healthcare system. Those can be a social determinant of health or health-related social need focused efforts that connect directly to the official healthcare system.
Emily, one thing I might just jump in and add to what Evan is just saying, we have many of our rural hospitals that have done great work around their community health needs assessments. States may want to make sure they're aware of and looking at those assessments for common ground that they can help support. But much of that work has started to be outlined and done, and maybe some of the RHTP funding can move some of the community health needs assessment findings forward, because they have a good handle of that. They've been doing it for a few years. They've seen changes and seen the impact that addressing some of those community partnerships can make. So that's another place for people to look, is for the good work that the hospitals have done around that.
Thank you. And Nick, do you want to speak to some of the innovations around how to get that information out to people and connect those dots?
Yeah, certainly. When we talk about health-related social needs, one of the key components to getting that information around is direct investment into CIE solutions, HDU solutions. The naming, of course, is still in flux as to what those exactly are and what we're going to call them. But that's really one of the key ways that these community workers plug into the needs there and get information about people that need services in their communities, do referrals, case management, all of that sort of really important stuff. And there's a great opportunity here for some direct investment into those systems to kind of improve all of those outcomes.
Yeah. Get back to the second half of that OT question, was sort of how to connect and who to connect with. Many states everybody's approaching this a little bit differently. So we have seen a number of states that have issued requests for information. Others have set up more informal options for sending in information. So I think it is very state-based what the best way to connect to your state team who's putting this together as a proposal. Often the state offices of rural transformation or rural care are the ones who are really spearheading this work. I believe that question came from someone in Nevada, and we can send you directly after this information about how that process is working there. And if there are others who would like us to reach back out to you with kind of what the specific process is in your state, everybody's jumping into it in different ways, and we can certainly get folks more details around that. Lisa, a question for you on the long-term care space. Are there any examples for how this funding might be used in the long-term care space with either assisted living facilities, skilled nursing facilities, and rural areas?
Yeah, so I think that kind of the direction from CMS is a little unclear on nursing home, assisted living types of opportunities in rural space. But we all know that our hospitals and our nursing homes, our assisted living, have relationships in ensuring that care is provided that keeps people from returning to hospitals unnecessarily. And so there may be opportunities to do some pilots that increase the connectivity between nursing homes and hospitals for shared information, for improving handoffs, and for allowing for care to be provided in the nursing home versus transferring a resident or a assisted living resident back into the hospital. So I think as we look at solutions, we have to think again of that continuum of care and partnership of how do we reduce burden on providing care in higher levels and higher cost that can be addressed in appropriate settings by developing those partners and relationships and collaboration that Jen and Evan have touched on a number of times today. So I think we have to keep that in mind, but I think until we see kind of further details on where funding can be used, we might have to move cautiously on what those opportunities are.
I want to elevate just a couple of comments that have come in the chat, a certain amount about the importance of multidisciplinary teams in this work, and I think that just can't be emphasized enough, and trying to really get people working at the top of their license and getting the care from the most important person to deliver that, not assuming that everybody needs a neurosurgeon, as one commentator put in here. We are going to move into getting some final thoughts from each of our panelists around takeaways. So if you could spend just a minute or two talking about some of the key takeaways that you really want people to leave here today carrying with them. And Lisa, I'll turn to you first.
Thanks, Emily. I think we have to remember that the rural health transformation programs and the funds that are associated with that kind of are a conduit by which some solutions can be funded to reduce the impact of the Medicaid funding cuts in rural facilities. However, a few comments that we've seen, we know that it's not going to make up for the deficit that many of these hospitals are already operating under and will probably increase. But I think we have to remember the true purpose of what we're trying to accomplish here is ensuring that our rural populations continue to have access to needed healthcare services in the communities in which they live. That's work that has been ongoing for years, and I think we have to continue to be creatively innovative and think through how do we manage that imbalance. I think that we have to ensure our solutions are moving towards accessibility and losses in funding. And I think we have to make sure that we're not just taking something and fixing for one unit of healthcare and having a negative impact downstream or an ongoing cost added that will continue to be unfunded. So I think we really need to be aware of what our solutions are hoping to attain and then measure them. I think as we work together, we can find those solutions, but I think that we're also going to have to work alongside accountability and transparency to ensure that what we're doing meets the mark. And if it doesn't, that we're not afraid to say, wait, that's moving in the wrong direction, let's start again. Because I think we have to really measure both our successes and our failures, which sometimes is where we learn the most, to really maximize the impact to addressing the loss of revenues.
Jen, thoughts from you?
Yeah. So I think if there is one message I can leave people with, it's that sustainable transformation in the rural space really does happen at the intersection of quality, safety, and community-driven change. So rural communities, we've seen it time and time again. They already bring a lot of very incredible strengths. And when we combine those strengths with proven approaches to improving care, the results are impactful and they're sustainable. And somebody made a comment about quality improvement and patient safety and how does that impact the financial sustainability of the hospitals. And I do just want to just say that improving quality and systems alone is not going to fix or erase the financial challenges of that the rural hospitals are facing right now. I don't think that this program is going to be a silver bullet, but what it does offer is a way for us to strengthen the foundation of rural care while those larger financial issues are being addressed. So if hospitals are going to survive, they need both sustainability or stability and a path towards sustainability. So making sure that our financial survival and quality improvement are moving in the same direction is really where we need to start to see real sustainability. So no, quality and systems will not solve the funding gap on their own, but they will make each dollar that's available work harder for those rural facilities. We really want the Rural Health Transformation Program to be seen as a catalyst. I think Lisa mentioned that. It really gives us a unique ability to align federal resources with local leadership. So solutions are homegrown. They are relevant to those local communities, and they're not dictated or forced.
And I see you nodding there, so let's go to you next.
Yeah, I just second everything that Lisa and Jen said pretty much. But also, I'll just again kind of reiterate. I guess one piece of excitement that I am feeling is in this crisis, right? I'm seeing rural health leaders, at least in my state, actually kind of come together and try and start to have some of these conversations. That's something that we haven't really done. So they're like actually planning. Maybe we can, again, like form a rural hospital network. That's a clinically integrated network, and then we can share purchasing and share data and things like that. We could do that. There hasn't been the impetus to do that before. Again, that's not going to solve all of the problems, but it may solve some of their problems and solve some key pain points and allow some innovation like the things I was talking about around specialty networks or different payment strategies, value-based payment, as well as, again, thinking about access in ways that make sense for people in communities rather than access from a single organizational entity perspective. So states being really strategic, and the partners that they work with being really strategic and thinking about that collective benefit. What is the collaborative strategy that improves certain things, that solves key pain points, that perhaps even extends access in ways that we wouldn't have anticipated if we didn't have this catalyst for change. So I guess not wasting a crisis is one of the key points, that we have really the opportunity to create something that we've only talked about before. And so I'm excited in some ways to see what we'll be able to co-create together, right?
Yeah. Nick, final thoughts from you before we close.
Yeah, certainly. And I'll kind of add on to that, opportunity here and focus specifically on the interoperability opportunity that exists here. Interoperability is both a buzzword and a boogeyman and all sorts of other things. But the opportunity here is real to actually increase and implement real interoperability, not just to check the box, not just because you have to, but because it can actually help. It can help not only the people that are getting care, but also the staff that now don't have to call to share information or mail out information to another clinic so they have that. There's interoperability here between clinics, between the states, and between the community health workers that are also involved in providing care to this population that can be improved with these dollars.
Yeah. Finally, we'll turn to Andrew.
Yeah, I was going to talk about a little bit about more on sustainability, but I see a question in the chat around how we can think more broadly around national networks for rural care, including data sharing, and kind of on the theme of that and what Nick's saying with interoperability. All of these things are somewhat interrelated. Interoperability is sort of the mechanism of how you're going to connect up to these national networks. One of the other comments I made was don't go at it alone, meaning how do I get my data into these national networks, or how do I get data from these national networks? That could be partnering with the HIE. It could be partnering with your EMR vendor, EHR vendor, who can get your data connected to those national networks, which is technology. How do we change your technology to kind of solve problems you're trying to solve or have data that you don't have in your system to provide better care? So really, I think that thinking about interoperability is huge. And how do you sustain these systems that you're building so that you can, fund them and pay for them well into the future, not just a kind of pointed, big bang sort of system upgrade. So,
Thank you. We are coming to the close of our time here. So I just want to say how much I appreciate all of you joining us here today, all of you on the panel and all of you in the audience as well. Thank you for taking time out of your day to join us. We'll do our best to follow up with answers to the questions that we weren't able to get to today. And we realize there will be more questions as further details emerge about the program, as well as some large unanswered questions that I think we're all struggling with, including that rural finance crisis piece. There are lots of great people out there working on this, so we encourage you to plug into what's happening in your community, connect with your state offices of rural health. There are national groups like Civitas who are posting great materials, and CMS will be doing a number of webinars that are yet to be scheduled, so please engage with those as well. I think all of us believe passionately in the importance of rural communities and their needs, and we really appreciate having the partnership of all of you in trying to make this program a success. Thanks for joining us today, and we will be in touch.